On behalf of Hospice of the Piedmont, welcome to the E-Series, an educational webinar aimed at engaging our community, exploring relevant topics, and educating about ways to connect with our organization. Funding for the E-Series is provided by the Dr. John A. Lusk Fund for Hospice and Palliative Care Education. My name is Ryan Biagini, and I'm your host. Today's episode is Exploring Our Community, Distilling Health Disparities, a conversation between CEO of Hospice of the Piedmont, Trent Cockerham, and Curtis Holloman, the new Executive Director of the Foundation for a Healthy High Point. Trent joined Hospice of the Piedmont in 2013 as the organization's third CEO since its founding in 1981. He has 25 years in healthcare leadership. Most recently, he led the organization in navigating a successful merger with Hospice of Randolph. Thanks for being with us today again, Trent.
Thanks, Ryan.
Curtis Holloman joined the foundation in January 2021 and serves as the executive director. He comes to the foundation with 20 years of philanthropic experience working with communities to address conditions that influence health. Prior to joining the foundation, Curtis served as a senior advisor and senior director of grants and programs for the Foundation for a Healthy St. Petersburg during its startup. Curtis was the deputy director for two Robert Wood Johnson National Program offices, including the local funding partnerships based at the Health Research Education Trust at the New Jersey Hospital Association, and Southern Rural Access Program based at the Department of Family and Community Medicine at Penn State College of Medicine. He served as the health director for both Scotland County and Sampson County health departments and started his career working with a group of community rural health clinics in Robson County. He earned his MBA at Temple University, an MA in political science at Appalachian State University, and a BA in public administration and political science at the University of North Carolina at Pembroke. As a North Carolina native, Curtis is excited about the opportunity to return home and work locally in the greater High Point area to improve health and wellness. Thank you for being with us today, Curtis.
Thank you, Ryan. Thank you very much.
So I know the two of you have much to talk about, so let's just jump right into this conversation. You can take it from here, Trent.
Thanks, Ryan. So Curtis, first of all, welcome back to North Carolina and a heartfelt welcome to High Point. We're so lucky to have you here in our community. As we sort of jump into our conversation today, I think it would be important to give folks who are watching and listening to this a brief overview of what the Foundation for a Healthy High Point actually does.
Good. Well, thank you, Trent. And I'm very excited about this conversation today. And I just want to say, so many people have been welcoming and inviting. It's been a really good transition here in relocating to High Point. So I just wanted to kind of thank you for an opportunity to participate in your E-Series here. I think the Foundation for a Healthy High Point is what we call in the business of philanthropy, a health legacy or a health conversion foundation. It came about in 2013 with the sale and merger of the High Point Regional Hospital with the UNC Health System. And then most recently, back in 2018, there was another realignment or merger with Wake Forest and the hospital here. So as a result of those transactions, dollars were set aside to establish an endowment that would benefit health of the community as well. So that's a bit of kind of the technical aspect of who we are and what we are. We have a board that governs our activities, and we make grant investments in the community that impacts wellness and health. And I'm happy to talk about some of the work that we're doing, and particularly some of the planning and the movement and the changes of the foundation over time.
Yeah, so thank you for that really nice introduction to the foundation and the work that it is doing and that you are embarking on now. Curtis, I'd like to go back just a little bit. Ryan mentioned that you were a public health director in both Sampson and Scotland counties at some point a little further back in your career. But this is a conversation about health disparities. These are things that we've been sort of following and learning about over the last several weeks. And I'm really curious if you might be able to share a little bit about your experience as a public health director and what you saw play out related to health disparities, particularly in rural North Carolina. There are parts of our region that are very rural, even here in the middle of the Piedmont Triad.
Yeah, Trent. And when I listened to that introduction by Ryan, it's like I realize I've been around for a while. So it's kind of like, yeah, I mean, when I first graduated from Appalachian way back when, it seems like, I was lucky to sort of fall into Robeson County and do some work with some folks who were building and developing a group of community health centers and rural health clinics. Now we refer to them as FQHCs, federally qualified health centers. And there I was able to just kind of learn the connection between clinical primary care services and then what's going on in the community. As you know, and folks who know Robeson County is very rural. You've got three different populations there, majority populations. The largest number of Native Americans east of the Mississippi, but the majority of them reside in Robeson County. You have a very underserved African American community and a very rural white work farming community at the time when I was there. So we had a playground in which to kind of take our medical services. We would recruit doctors to come in and work with us through national programs that gave us access to doctors. But we also just immediately saw the connection between the community and what's happening in communities versus what our doctors and our physicians are seeing in the clinic. And that for me sort of set this understanding of, this was back in the early 90s, when it was all about access, it was about medical and clinical services. And we were just starting to think about social determinants of health. We were just starting to think about we need to do more if we want to prevent poor health outcomes for individuals and for the community. We needed to do more than just treat disease and sickness. Mm-hmm. So when I finished that work, I was really fortunate at a very young age to become to be appointed the county health director in Sampson County, and then eventually in Scotland County, and sort of moved up the road, up 95 a little bit into Clinton. They're working for a great group of people. I can see all of them now in my head. They took this kid with some ideas and some energy and really allowed us to kind of look at public health and start shaping public health in a way that would be more responsive to people. I think that's one of the things that I wanted to do there. And when you talk about the disparities at that particular time, North Carolina was very focused on infant mortality. We were very focused on low birth weights. There was such a disparity between what was happening in other areas of our country, but we were doing just as bad as third world countries, and underdeveloped countries. We've made some improvement over the years, and there's still areas in Guilford and other places where we need to do even more. But that was how we really started focusing on disparities there, and did a lot of work around that. Trent, we also saw the influx of immigrant community, right? And our farm workers coming into the country. In Sampson County, we had the pork industry. So we also, the issue of access, how do we include those residents, particularly when it comes to communicable diseases, it comes to, infectious diseases that impacts all of us. We know with COVID, there's no borders to these issues. So we did a lot in terms of how do we work with that population and that community. And just to list a couple other things, maternal care coordination, African Americans and non-whites. We were just seeing such a disparity in terms of access. So those were some of the early disparities that we focused on in the health department back in the early 90s.
What's so interesting is so many things that you talked about. You talked about you talked about infant mortality. You talked about infectious disease, which generally is applicable more to an adult health population. So you're really talking about a lifespan. So these are issues that begin in some cases at a very early age and then may continue for some populations disproportionately for decades, I suspect. Is that fair?
Oh, it's definitely fair. And that's what I always go back to where I started with the community health centers. And we had that life cycle approach. And in public health, we have it as well. And one of the things that we know, and from the work that we've done, the research supports that if we can start early in that life cycle, right? If we can work with, and that was why we focus on infant mortality, prenatal care, care coordination, child care coordination. It's because we knew that if we could start early working with families that didn't have the resources of families that were doing well, if we started working with those young mothers, we started working with those families and work with kids between the ages of 0 to 3, that when they become 5 years old, they're ready to learn. And we can see in the life cycle, you can sort of follow that trend, okay? If we have kids who are ready to learn when they start school, they have the emotional support at home. One of the big indicators of being ready is having been read to. Kids, if their parents or their guardians read to them, they excel. And it's not just kind of with good grades, their emotional, their well-being is improved. Yeah. And I like to make this point because when you speak about the life cycle, if you just kind of think about this visual, you get a young African-American kid, right? If they're not ready when they enter into first grade for a number of reasons, they haven't had the family support, right? They haven't had the reading, the learning, the food insecurity, sure. The trauma that goes along with not having these things that a lot of us just take for granted that makes us very healthy people. So, they just start out behind. Mm-hmm. So you'll get the problems in school, paying attention, they fall behind. Next thing you know, you're in school suspension, then you're suspended from school, expelled from school. Then some of these kids go on to get in trouble with law enforcement. So, you're in, jail and in prison. So that's part of addressing issues early in the life cycle can prevent what we call this prison pipeline, so to speak, that you hear a lot of us talk about in the African-American community and low-income communities in general.
So I think, I've heard a few things that you said that are really key. It's developing responsive solutions, right? It's understanding the needs of the communities that are perhaps disproportionately underserved or disproportionately represented. There are many factors, as we've learned over the weeks, as I've learned just in my own reading, that really affect these populations. You have, as you noted, a prison pipeline, right? That term. We have poverty, food insecurity. There are issues of systemic racism, for example. All of those things sort of are social in nature. So these are these sort of social determinants of health. We talk a lot about that. We hear a lot about that, I think, now in the mainstream media more than we probably ever have. But that's what you're talking about. You're talking about social determinants of health and how they affect health outcomes. Might you talk a little bit about that?
Sure. I think, and when I look back, because I just had a birthday, so I'm kind of very reflective these days. And
happy belated birthday.
Thank you very much. So it causes you just to be sort of reflective and what has changed. And one of the things, the conversation back in the late 80s, as I sort of joined the profession, the workforce, we do see now, as you've pointed out, this conversation about equity, so it's like disparities or preventable disparities. Now we're looking at issues of equity. And I think with equity, we're talking about the question, do you have the opportunity to excel and the opportunity to experience good health and healthcare and access to those systems? So I'm really delighted because that's the question that we're asking now. We're moving into, back in the day, it was more like, a service, providing a service and coming into the building to provide a service to. And we had that going on. Now the conversation is more external. What can the community do? And what in the community do we need to make sure that access to good health care is accessible and is more equitable? Because when you start this conversation about social determinants, and I like the term social influencers. Social determinants is such a public health kind of data term. But in the medical profession, you hear medical people talk about social. They use other terms to describe this here. But social influencers, if you think about all the conditions that's going to impact a better health of a person and a community. And I think the conversation we're having today is more about that, and it's less about the clinical care. And Trent, I wanted to point, and I know you know this too, that if you look at what influences the outcome of individual health and the health of a community, there are a number of factors that we can look at. For example, health behavior, right? You can, that's whether or not, that's diet and exercise, which I need to do more of that. I have to change my behavior to do more of that. But you also have, we've had a history of tobacco use, and we've seen how, cancers and health has improved and cost of healthcare as less people choose to smoke and use tobacco products. Alcohol and drug use, even our behaviors. If you think about COVID right now, if we wear a mask, if we keep our distance from people and we're washing our hands, those behaviors can help us live longer. So if you look at the factors like health behaviors, and then you start to look at clinical care, what happens basically in the doctor's office, in the medical office, and access to that and the quality of care you get there, that accounts for a part of what influences health outcomes. And just two other factors I'll mention, social and economic factors. This is the category that accounts for 40% of our health and health outcomes as individuals and as a community. And these are issues where you're talking about education, you're talking about employment, income, poverty, people who can earn a livable wage. We know that they are healthier and our society is better for it. Family and social support. These are sort of the wraparound services outside of the clinic and the medical office. These things are important. And of course, community safety, violence. Do we have, law enforcement? Do we have other efforts in our community that keeps us safe and healthy? And I'll mention the fourth factor, and that is physical environment, okay? Drinking water, housing is a very important piece of that. And of these four factors, the one that accounts for the most in terms of improving our health and our health care and changing the outcomes is certainly social and economic factors and health behaviors. The one that accounts for the least, of course, the physical environment, drinking water, those things like that, housing. But the other one that a lot of people are surprised about is the clinical care. It only accounts for 20% of improving the health of individuals and communities. So we can go to doctors, we can go to emergency rooms, we can have the best system there. We're only going to improve or protect the health for only 20% of us.
Right. You know, it's interesting. I've worked in healthcare for over 20 years, and I think I've long understood that uh, that life happens outside of a healthcare setting. And really, these social influencers are really life. These are the factors that influence the way we live, the way we go about living. And it makes sense that all of those things really have a tremendous impact, greater than the clinical care that we're receiving on our health and well-being. So, you know, we talked about health equity, and, you know, oftentimes I think people may think about equity and equality as the same. Can we have a brief conversation about that?
Sure,
Is there a
sure, sure.
difference?
Yeah, yes, there is. And actually, I've been thinking a lot about this, particularly as we reflect back over the past 12 months. I mean, which has just been horrific. But Trent, also what we've seen in the past 12 months, I think a lot of people have in a different way. Not just you and I who live and breathe and work in this environment for so many years, but I think the average person have really seen how a pandemic, and the disparities of that, all right, can impact a neighbor and can make a difference in terms of life and death as well. So I like this, and I think the conversation about equity and health equity in particular is just unbelievable. I think even 10 years ago, I would not have thought that that we could have such conversations, and that is very hopeful, as we're moving forward. And I think when you look at equity versus equality, um, equality is that you and I can have the same thing, right?
Mhm.
You have access to a doctor. I have access to a doctor. We both have, income that can sustain us and our families as well. But the difference, and I'll make it kind of personal here, Trent, if you don't mind.
Yeah,
You,
sure, please.
you as a white male
Mhm.
and me as a black male, we're both North Carolina boys, right? We're born and raised here. But, it's all about where we work, live, and play location. So you grow up in one environment, I grow up in another one. So our lives, we just have different life experiences.
Sure.
So now here in Guilford County, okay, in High Point, we go to the doctor's office and we have the same level of services. There is a need to kind of look at, for some folks, we need different tools, right? We need a different approach or understanding. There's a cultural difference. When I go to my doctor, they speak a different language. Sometimes I have to translate, or I go to a doctor who really fully understands me.
Sure.
And all of us do that. And I think these are certain aspects that relate to equity and equality. So we can have access to these services, but some of us need different tools, because even with that access, there's a disadvantage. So you may need different resources, you may need different tools or methods. Another example is your Spanish speaking individual. So you show up, let's say they go to the same doctor that you and I go to, they need translation, they need language services, okay? There's some folks, they need transportation to get there. So when we are planning and looking at our community, we need to take into account, and I think that's on a very simple level, that's what this equity look is all about. So we can have equal access, but equity means the equal opportunity and the tools that we need so that we can achieve the same level of health care.
Yeah, so it's interesting, you know, it sounds like we're really sort of talking about health equity as the beginnings of sort of a solutions, a responsiveness to disparity, right? It's the beginning of how we begin to deploy the resources that people need, rather than just assuming that everybody needs the same thing as everyone else.
Right, exactly. You just nailed it there. And so having the conversation about disparities is certainly important because we can prevent those.
Right.
But then when you start, okay, you address the issue of disparity and you still see that there's a difference here. So then I think we have to look further at the members of our community. We have to look at, where folks live. What are the other things that we need to incorporate or to assist or to help make sure the system responds differently?
Sure.
And one aspect of this, Trent, is the conversation we're all having about, structural differences and systemic changes. And we know those issues are extremely important too when we start talking about social influencers or really start talking about how do we more equitably address the health system or our community in terms of responding, is that we certainly need to look at how these services are provided, but we also need to look at the structure and the system that are in there. And there are plenty of examples of how, because of individual attitudes and behaviors, that sometimes the system doesn't allow or for things to be equitable.
Mhm. Yeah, it's interesting. So to take that a little step further, just for folks who are listening, who may, there are a lot of stereotypes related to health equity and health equality, although we've just really sort of dispelled, I think, what many of those stereotypes are. It's about understanding what people actually need versus taking this, one size fits most approach. And so a lot of people would believe that when they begin hearing conversations around health equity or even solutions to beginning to solve disparities, right?
Mm-hmm.
They begin thinking about, well, that means that's less for me.
Mm-hmm.
That's where the ego and the id sort of take over, right?
Yes,
You're
yes.
going to take something away from me to give it to someone else. But I don't think we're talking about a redistribution.
No, no. I think I would put it this way, Trent. It's not like a zero-sum game. All right. So it's sort of, and I think around a lot of these issues, when we start talking about social factors and social conditions, and particularly economics and resources, um, it we do, and particularly those of us, myself included, who are very privileged and for whatever reason we are where we are. A lot of hard work, a lot of luck, and a lot of people who helped see what opportunities we needed, okay, to get to the life and the lifestyle that we have now. But clearly, this notion that if we focus on one community or group of people, or race, ethnicity, sex, whatever the category is out there, that if we are helping to address the issue of equity, that somehow we're taken away from the whole. And that's just not true. Actually, there's a benefit and a gain for the whole when you have healthier people and for our society. I mean, we've seen that. I mean, when people are healthy, they live longer. They have a longer quality of life. They contribute to our economy. Okay. There's a personal fulfillment of happiness that we see in our society and as a country. So we are experiencing, so we do all benefit and rise from that. I think, and in some cases, to be honest with you, sometimes the political dialogue and conversation sort of wraps around the notion that, what you do for one is taken away there and there. But if you look at the social science and you look at even the economics of these things, of improving the health and addressing it from a community standpoint, it's much more sustainable. There is a cost benefit. It's much cheaper to prevent than, and you're familiar with the cost of the medical system at the end of life there. So there are just really tangible benefits there.
Yeah, it's interesting. Roughly 60% of all bankruptcies occur because of some sort of medical event, right? A significant illness, and about 40% of those will occur within the last 12 months of life. And so, much to your point, if we as a healthcare system in its broadest sense can begin addressing these social influencers and being able to create an upstream approach, a responsive upstream approach, then we all benefit in an economic sense. You know, the cost of not addressing this is certainly greater than the cost of addressing it. I mean, I think there are some statistics that point to about $93 billion worth of cost is within the healthcare system is born out of issues related to disparity. And I suspect it fits into all of these four buckets that we've talked about. Similarly, you know, just as an aside, we also know that there are populations that suffer very differently and disproportionately from really treatable and preventable diseases like hypertension, which we know leads to end-stage renal disease, and disproportionately so in communities of color. And I mean, those are sort of known facts. And so that's a part of that is clinical care, but a part of that is health behavior, and a part of that is all related to these social influencers of health.
Yeah, it's amazing. You know, and as we sort of talk about it and have a conversation, you can really see how this fits in. I was going to mention the point that you talked about bankruptcy at the end of life. We know that wealth and transfer of wealth is also a leg up to equity, okay, in our society, and being able, family members who can transfer that wealth or pass it on through inheritance, that's sort of a leg up in there.
And that's really important for people. I mean, you know, I think by and large, if we look at sort of the way we live, don't we all want to be able to leave something to people who are very important to impart something meaningful to them? It looks really differently for a lot of different people, but I think that's a really important social consideration. So do you see this as sort of being the approach of community-based philanthropy related to health disparities, and more pointedly health equity? Do you see this as being sort of the tipping point that we're arriving at now? Because it seems as though through our conversation, the conversation over the years, over the last couple of decades, has changed pretty dramatically. I suspect the approaches to that have too. So what are some of the things that you've seen, or things that you think are maybe even more needed?
Yeah, that's a good question. Yeah, I think certainly in health philanthropy, we've seen it change. And I think philanthropy, if you look at, you know, its role in terms of convening and creating, helping to set the agenda and having conversations. For example, the Robert Wood Johnson Foundation that I was affiliated with had done that over the years, and we see how these issues, you know, tobacco smoking is one of those. I would say, I think in philanthropy, we've seen this change. A lot of place-based foundations and healthcare conversion foundations like us have sort of adapted a framework that is what I call upstream and focusing on the social determinants of health in selecting those issues. I think they're also looking at, like, how do we have impact in community? How do we work collaboratively? How do we help with our resources? How do we fund collective impact and collective action efforts that are taking shape, and bring together all the players of a particular system to come together and find solutions that can be implemented? Or we can find changes to policies by helping to shape policies, and also helping to make changes in the system so that people benefit. That's a big impact. So a lot of foundations are changing and positioning that way. Just as a contrast, Trent, in the past, foundations were seen as like, oh, I want to go get some money. I want to get a grant, okay? And then my nonprofit friends were like, okay, I got the grant. I'm going to go do the grant. I think now it's more of a partnership. And here with the Foundation for a Healthy High Point, the nonprofits that we invest in, they are our funded partners. So we will, and we're working with them in a way, not just to provide some resources, and we will, of course, continue to do that, but how can we work with them so that we can bring resources to them so they can be change makers in their communities, so they can improve the infrastructure, and they can start looking at their work beyond their four walls and look at their work. And we have great partners here at High Point, folks who are already doing this and coming together. And I'm looking forward to working with them and supporting those types of efforts. Another part of philanthropy is, being a place-based community, not a community foundation, but a place-based foundation, is how we can kind of leverage other funders, to come in and work with us and partner, and how we can bring in strategic, what I call strategic partners and experts who can help work with us in our community. But most importantly, it is about the partnership. It's about working collaboratively and bringing the resources that we're so fortunate to have and have it work in the community in a way that is changing these upstream issues, that is influencing the social factors that can improve our health outcomes early in the life cycle, but certainly throughout all parts of that life cycle.
Yeah, it's what you cited. It strikes me as it's a movement from what you said really struck me. In the past, your friends who worked in nonprofit, it was, okay, I get the money for the grant, now I go do the grant. It's the difference between a transactional approach to systemic response or responsiveness, and more a shift towards a transformational response to a sustainable systemic response.
Yes, definitely. That's exactly where we are and where we need to be as one player in the community, right? As one partner in our communities. How can we become more transformational in the way that we work with individuals and the way that we make our investments into community?
Right, because that really is the shift between building a clinic, from to use an example, I think we talked some moments ago, between building a bricks and mortar clinic to actually taking something to the community, to the census tract, to the neighborhood where it has the potential to have the greatest impact. It's that difference between one size fits most, or everybody needs the same solution, to let me take the solutions that actually are most effective and most impactful to those populations, right?
Yeah, and I think philanthropy sort of being the third sector here. I mean, government is limited, and when it comes to government, just like everyone else, I want those dollars to be used on things that are going to work. Those are our hard-earned tax dollars.
Sure.
The private sector, they have their interests as well, helping to create jobs and wealth in our community. And I think foundations and philanthropies like the one like our work here, we can take risk in working with communities, and we can fund those things that government and the private sector are not incentivized to fund as well. So anyway, I'm excited about. And Trent, I don't know how much time we have, but I did want to share one of the things that we're doing with the start of my work here and with our board of directors is that we're going to be taking a look at our strategy, sort of revisiting after 5 years or 7 years of operation. It's sort of revisiting our strategy, how we go about impacting or trying to help be a change maker or change leader in our community. And then also take a look at the areas that we're focusing upon, and do this through the lens of social influences, or that upstream approach, which we've moved that way as a foundation. And I think this is going to kind of move us in a way that we're doing it in a much more intentional and much more purposeful way as well. And then one aspect of the strategic planning that we will soon launch and start is that there's a community engagement piece, right? So we want to look back and see what work did we do over the past 5 years, and what impact did we make and have. A lot of good things have happened, a lot of good work. And then we want to kind of revisit, what are the needs out there? How have they changed over the past several years? And then we want to really engage the community and hear from the community. What is it that resonates with you? Speak with individuals, stakeholders, and really have that input into our process, so that we can sort of redirect, reaffirm our work and moving forward. That we'll have a much more responsive agenda, or that we can have even greater impact. So,
Sure. Interesting. So I have a couple more questions for you, Curtis, if I might.
Sure.
We've just now lived through, the most difficult, challenging, year of our collective existence, right? We've come off a year of a pandemic. We're still much in the throes of it, though it seems as though we're making great strides towards getting to the other side of it. Do you think that this period of time that we've come through has given place-based philanthropy organizations, or even the larger healthcare system, opportunity to sort of reflect upon, or even see that we've been able to shine a bit of light to highlight some of these things that we've talked about? We've highlighted, I think, many factors related to vaccination uptake, right? We know that how that disproportionately affects different communities for a lot of different reasons. Do you think that it has helped push this conversation forward? And do you think it's given us a greater amount of awareness?
I like that question. And I was talking earlier about me sort of reflecting back, and I think a lot of us have done that. And I think we're doing it now too, because it's with the creation of the vaccine and the supply increasing, we're all a bit more hopeful. It was a year ago that this week that things just kind of shut down.
Right.
And I remember I was in New York City the weekend before in a studio audience with about 500 people sitting shoulder to shoulder. And then a couple of days later, all the news comes out, like, there are cases in New York, there's cases. It's not just, and I think that traumatic experience, right, that we all felt of like shutting down, staying in, it's been horrible. But I think out of that, there's been a lot, and there will be even more reflection and more coming together. I'm just so moved by people. We have the Zoom and kind of this virtual connection, but still yet we're finding a way to connect. And I'm connecting with people who, it's not family, right? It's not that first tier of friends and close friends, but it's even with strangers in a way of like having conversations with them. So I'm very optimistic, and I think systems and like, philanthropy, health philanthropy, these healthcare systems, we're all sort of responding. I mean, it's been a horrible lesson in terms of disparities and how pandemics impact some folks and not others. And I'm hopeful that we can take those lessons, and when we, on a small scale, even if you're doing your annual strategic planning or your 3-year strategic plan, that this is new information and we're having different conversations than we had 5 years ago, 10 years ago.
Yeah.
So
It's changed our collective reckoning for sure. You know, Curtis, we've got just a few minutes left. I want to ask you just one last question. We've talked about a lot of really important things today. I've learned a tremendous amount, and I'm so grateful to have really been able to participate in this with you. If there are one or two things that you think about that you'd really like for folks who are watching this or listening to this later, that you'd really like for them to take away, what would that be?
yeah, that's a good question here. You know, it's just going to sound corny, okay? But, you know, I want people, you know, to be encouraged. I think it's encouragement that we need, that these issues don't divide us, okay? Our differences, the disparities, the lack of equality, they don't divide us. They should bring us together. And that when we all connect, we all become the better for it. And I think I know that's what I've learned over the past year. And that's what I would want people to take away. And then to be a part of, you know, in a very intentional way, no matter what your life is or where you are, to figure out, you know, where can you play a role in addressing these issues of disparities. And it starts with you, with the individual, you know, own health, you know, our own health care, and those that we love and care about, making sure that we are healthy, and that we're connected with a system of care, but that our social environment is also one that's going to keep us safe and well.
Sure. I appreciate that. You know, it's interesting as in our own organization, we've gotten lots of organizational responses to COVID-19 over the last year. I've had I don't know that I call it a unique privilege, but it's been interesting to have to craft those messages out to the staff on a frequent basis. And I always end them with sort of the same thought, which is our responsibility is to take care of ourselves and each other. And I would love to say that Lester Holt on NBC Nightly News stole that from me, but I don't think he did. But I think that's what you're talking about, really. Is that we've got a collective sense of responsibility to take care of ourselves, our own health and well-being, but also to do our part to help improve the health and well-being of others, because when we're all healthy, we all benefit. Curtis, thank you so very much. I'm going to punt this conversation back over to our host, Ryan Biagini.
Thank you, Trent. It's been my pleasure.
Yes, thank you both for allowing us to sit in on this conversation. Curtis, the work that you and your team are doing at the Foundation for a Healthy High Point is groundbreaking and community changing as you come alongside organizations to address health disparities and these social influencers that you described for us this past conversation. Thank you for sharing with us your knowledge and many years of experience in the field of public health and in health equity. Your passion for philanthropy, coupled with the resources and the strategic planning of the Foundation, are sure to make lasting impact in shaping our community for a more healthy future and a more healthy High Point. As you and Trent discussed, we look forward to working in conjunction with you in the future as a partner striving for creating new opportunity for this upstream change in our community. So thank you again for your time.
Thank you. Thank you both.
I'd also like to thank all of our listeners who have joined us today for this discussion exploring our community distilling health disparities. As a reminder, this series, as well as all of our other E-Series episodes, are available on podcast for download at both our website under resources, as well as on SoundCloud, Google, and Apple Podcasts. We hope you will tune in next time as we wrap up our current series with a conversation entitled Exploring Our Community, Navigating Health Disparities at End of Life, where CEO Trent Cockerham will talk with Dr. Holman, Hospice of the Piedmont's Vice President of Medical Affairs and Chief Medical Officer. As we've learned more about health disparities and how they affect the communities we live in, Trent and Dr. Muggsy will discuss how health disparities shape end-of-life experiences and what our organization is doing to create more equitable solutions. So we hope you'll join us. But until then, I'm Ryan Biagini, and this has been the E-Series.